Anxiety is an emotion that we all experience. It serves a useful function to help alert us when we need to pause and think about upcoming situations. But for some people, anxiety towards social situations can be maladaptive. These individuals with social anxiety disorder make drastic and disruptive life choices in order to accommodate their fears of social interaction. Sadly, this disorder is often called a disorder of lost opportunities due to the many unrealized experiences which an individual denies him or herself. Social anxiety disorder, also known as social phobia, is the most common anxiety disorder in the United States, having a lifetime prevalence of 13% and a 12-month prevalence of 7.4%. Individuals with social anxiety experience excessive fear and anxiety in social situations. They have exaggerated concerns about being negatively evaluated by others, they anticipate embarrassment and humiliation in social situations, and they fear that their anxiety is obvious. While everyone experiences shyness and self-consciousness from time to time, those with social anxiety disorder experience distress and dysfunction out of proportion to what is socioculturally appropriate, which results in avoidance or distressed endurance. There are two subtypes of social anxiety disorder, generalized and non-generalized. Diagnostic interviews and self-report questionnaires are used in the assessment of social anxiety disorder. Numerous clinician-administered scales and self-report scales are commonly used, for example the Leibowitz Social Anxiety Scale and the Social Phobia and Anxiety Inventory. The etiology of social anxiety disorder is dependent on a variety of factors, although these factors can be grouped into three broad categories: generalized biological vulnerability, generalized psychological vulnerability, and specific environmental factors, which includes individual-specific experiences. Research has shown that the heritability of social anxiety disorder is between 0.3 and 0.5. Although the exact mechanisms of these genetic factors are unknown, twin studies suggest that neurobiological factors may be involved in the development of social anxiety disorder. One biological factor may involve the amygdala. In comparison to control subjects, individuals with social anxiety disorder tend to have increased levels of activation in the amygdala in response to negative social cues. Past research has shown that variability in infant behavioral inhibition is in part dependent on biological factors. Infants with excessive behavioral inhibition are at a greater risk to develop social anxiety disorder later in life, so therefore levels of behavioral inhibition may be interpreted as a biological factor. In addition to general biological factors, there are many general psychological factors which are associated with an increased likelihood of developing social anxiety disorder. Individuals with social anxiety disorder are better able to recognize critical and angry facial expressions, which may predispose them to be extremely attentive of negative evaluation. Additionally, adolescents who had an insecure attachment to their mothers as infants were twice as likely to develop anxiety disorders by late adolescence compared to individuals who did not have insecure attachments. There are numerous specific environmental factors which may put an individual at higher risk of developing social anxiety disorder. Parents in parenting play a key role. Children who are subject to overprotective or hypercritical parents have elevated rates of development of social anxiety disorder. Additionally, 13% of individuals with social anxiety disorder recall observing socially anxious behaviors in their parents. Bullying may also play a role in etiology. 92% of adults with social anxiety disorder experienced severe bullying during childhood. There are numerous factors associated with the maintenance of social anxiety disorder. Because they are phobically avoidant of many social situations, individuals with social anxiety disorder are exposed to fewer situations in which they can unlearn their disproportionate fears of negative evaluation by others and in which they can gain confidence in social settings. This avoidance then simultaneously reinforces an individual's fears and anxieties while also providing few opportunities to address maladaptive thoughts and behaviors. Cognitive distortions are irrational patterns of thoughts which perpetuate many disorders. They play a key role in the maintenance of social anxiety disorder. Some common cognitive distortions are high self-focus, the overestimation of negative repercussions from a social encounter, the beliefs of uncontrollability in a social situation, the self-appraisal of low social skills, and inappropriate use of safety behaviors. One key cognitive distortion involves anticipatory anxiety, where an individual experiences anxiety previous to an event, which heightens feelings of anxiety during and after the event. Even when exposure occurs, cognitive distortions can prevent extinctions of negative thoughts. Social anxiety disorder has an early onset. The peak age of onset is 13 years, and onset after 20 years is relatively rare. If untreated, social anxiety disorder follows a chronic and persistent course. One study found that only 15.1% of untreated individuals were completely remitted after 10 years. Numerous factors are correlated with increased severity and duration of symptoms. The breadth of feared situations, degree of avoidance, degree of symptom severity, parental psychopathology, and high behavioral inhibition or harm avoidance. Social anxiety disorder tends to be undertreated, and even if treatment is given, it tends to be delayed. Only 40% seek treatment, and many individuals wait 10 to 15 years before seeking treatment. Cognitive behavioral therapy, or CBT, is the first-line treatment for social anxiety disorder. Multiple studies have demonstrated that CBT is the most efficacious treatment in terms of improvement in outcomes. During CBT, therapists and clients engage in psychoeducation, social skills training, cognitive restructuring, imaginal and in vivo exposure, and video feedback. During cognitive restructuring, the therapist attempts to address and change the client's cognitive distortions. During imaginal and in vivo exposure, the therapist gradually exposes the client to increasingly stressful social situations so that the client can learn to extinguish anticipatory and situational anxiety. During video feedback, the therapist videotapes the client so that the client learns that the display of anxious behaviors is much less overt than the client may think. Acceptance and commitment therapy, or ACT, is a form of psychotherapy which is distinct from CBT in that it attempts to diffuse rather than restructure negative thoughts. While CBT attempts to change behavior through lessening the likelihood of maladaptive thoughts, ACT attempts to change behavior by decreasing the likelihood that clients act on these negative thoughts. Thus, psychological flexibility, mindfulness, and acceptance are stressed. The efficacy of ACT has been shown to be comparable to CBT in numerous studies, although it is less prevalent in the treatment of social anxiety disorder. Patients will sometimes be uninterested in psychotherapy, and for these individuals, pharmacotherapy is the preferred treatment. SSRIs and SNRIs are the interventions of choice for generalized social anxiety disorder and the most commonly prescribed medications. Their efficacy and tolerability have been demonstrated, although it should be stressed that CBT is more effective at improving outcomes. Among the catalog of SSRIs and SNRIs, there is not one medication which has superior outcomes. Long-term issues and relapse with SSRIs and SNRIs do limit their long-term usefulness as treatment. Additionally, because some individuals differ in which medication may ameliorate symptoms, finding an effective medication may require a trial-and-error approach. Benzodiazepines are effective in the short-term treatment of social anxiety, although there are many long-term medical concerns which limit their usefulness in treatment, including withdrawal, psychomotor impairment, and rebound anxiety. D-cycloserine, which is an agonist for the NMDA receptor, can be used to enhance extinction and has been used as an augment for psychotherapy, which has led to improved treatment outcomes. The non-generalized subtype of social anxiety disorder has generally been prescribed more as-needed medications due to the predictability of their issues. Beta blockers and benzodiazepines are common prescriptions to reduce the expressive components of anxiety, although many have noted that psychological dependence may develop. The side effects of sedation and cognitive dulling may outweigh anxiolytic benefits. Thus far, there is no clear evidence that combined pharmacological and CBT is more effective than either treatment alone. Various factors have been determined to be associated with less effective treatment: early onset, greater disease severity, and comorbidity with other anxiety disorders. Future research should address the issues of delayed treatment and undertreatment. The utilization of the internet and mobile technology should prove promising for this disorder of lost opportunities.